Great, thank you. Okay, so guys, I'm so sorry I couldn't take the classes last week because I was sick. I got corona positive. Today also I thought like I'll take a little class. So let's start. In last class we have discussed case of myocardial infarction. So which kind of myocardial infarction we have discussed in last class, guys? Someone? What was the case? What kind of case?
Acute coronary syndrome.
Acute coronary syndrome. What type of myocardial infarction?
Anstomy.
Anstomy. Exactly. Anstomy. And along with that, we have discussed about the sign and symptoms, differential diagnosis, and the treatment algorithm. Okay. Today, what we'll do is, today we'll not touch those things, but today we'll be going into the therapeutics deeper, and we'll see how we learn from the guidelines. Okay, so today I did not prepare any slides. I'll be talking about STEMI. Okay, what are the treatment patterns of STEMI? What are the timelines for different drugs? Like as many were asking the questions about thrombolytics, streptokinase, Antiplatelets and all. So we'll be discussing about the timings and the drugs and the doses and what time we should give, what time we should not give. Those kind of things we will be discussing today. Okay, so today we'll be discussing those things from the world famous ESC guidelines. ESC means European Society of Cardiology guidelines, which are recently, which have been recently published in 2020. So we'll be discussing those guidelines, and we'll be discussing what are the things we should, learn from those guidelines. Okay, so let me share the screen. Okay, first let me share the screen and let me tell you what is the simplest algorithm to treat STEMI and how we should go for it. Okay, how we should learn. Okay, so this is the simple algorithm. Okay, so here we can see that if the STEMI patient comes to your hospital, okay, comes to your emergency room, or comes to because there are multiple hospitals. See, first of all, there are primary care centers, then secondary care centers, community centers, then tertiary care centers, or maybe ambulatory cares. There are multiple things. There are multiple types of hospital, and in India, not only in India, everywhere in the world, PCI facilities are not quite common. Okay, PCI means percutaneous coronary intervention. Percutaneous coronary intervention means catheterization labs or interventional labs. These are not at all very commonly available, because one PCI lab, one intervention lab costs around 1.5 CR to a good number. So minimum 1.5 crore rupees, Indian rupees, you need to establish one intervention lab or catheterization lab. So it is not easily available, right? So it is available where they have either a good hospital or either the good number of patients, like in the big cities, right? It's not available in the towns or cities, or in the villages or in the remote areas. So you have to travel a lot to reach one interventional lab, at least for the treatment, right? And as we have discussed, STEMI and anstomy are the acute coronary syndromes where we need the patient to get treated as soon as possible, and we need to go for interventions at earliest, right, to subside the symptoms, to subside the, or to avoid the life-threatening situations. So we have to reach those intervention labs as soon as possible. So when you get the anstomy patients or STEMI patients, you should be very much careful, like where you are taking them and how much time it is going to take. You should be very much aware of the timelines, because timelines are very, very important in case of STEMI or in STEMI when the patient is having acute coronary syndrome, right? And guys, remember that day someone asked me the question like, what are the timelines and what are the things when we should give these antithrombolytics? Antithrombolytics means which can dissolve the clot, and those drugs are, Antiplatelets, streptokinase, tenecteplase, right? Those drugs we should be very, very careful when we are giving, because remember one thing. Remember one thing: you should be very, very careful when you are giving the drug. Like there are the conditions. There are the conditions of timelines. There are the conditions of timings. There are the conditions of patients related conditions, patient related factors. There are medical history related factors. There are medication history related factors. Like two things I'll tell you here: we should not at all give the antithrombolytic therapy or antithrombotic therapy in STEMI patients. Okay, and STEMI patients, we should not give this therapy. Okay, we should not give streptokinase or alteplase or tenecteplase in STEMI patients. Why we should not give? Anyone have the answer for this? Anyone out of you have that answer? Why we should not give in STEMI patients? This is not recommended at all in STEMI patients. Why it is? And we know very well that STEMI is also acute coronary syndrome. Then why we should not give in STEMI patients? Because in STEMI patients, the flow is restricted, but the restriction is because of the clot, not because of the plaque which has been broken and roaming around, So we consider that in STEMI patients, the plaque or the clot is quite developed for a longer time, and it is something which has been tightened with the fibrinogen, because all the thrombolytic agents or antithrombolysis agents, they work on the plaque formation, or they work between the cycle, between the anticoagulation cascade, not at when the anticoagulation cascade is completed. Okay, so in STEMI patients, we suppose that the anticoagulation cascade is it's still going on, but it is already completed, so it will not work. Antithrombolytic agents will not work in the in the situation where it is already done, and where the plaque is already hard, where the plaque is already kind of unbreakable. So in that case, we usually go for the interventions. In that case, we usually go for the reperfusion or revascularization, where we can remove the clot and put the stent. Okay, so we should not always remember this thing. In STEMI patients, we should not recommend it. We should not be recommending these antithrombolytic agents. And in STEMI patients, within the timeline means I'll talk about the timelines also. So within the timelines, and if the patient is following the criteria, if the patient is meeting the criteria, we should give these antithrombolytic agents. Okay, like suppose another contraindication for antithrombolytic agent is if the patient is having the old MI. Okay, and if the patient is having old stroke. Okay, transient stroke is there, transient ischemic stroke is there, then we should not at all give antithrombolytic therapies, because that is not recommended, because in that case the patient will get more hemorrhage, okay, more brain hemorrhages, and patient can die immediately. So in that cases also, so there are the contraindications for antithrombolytic therapies, what we should definitely follow and always follow before considering giving it in the emergency. So it is not very easy to directly, if you see the patient of PCI, if you see the patient of myocardial infarction, and you start giving the antithrombolytic agent, because antithrombolytic agents have their own consequences and own criteria to use, right? So we should be very, very careful when we are giving these things, right? we should be very much aware of all the criteria when we are selecting the patients for antithrombolytic agents, right? So let's see what we should give and how we should give. So STEMI patients who is a candidate for reperfusion. Reperfusion means STEMI. Okay. So initially seen at the PCI capable hospital. If the PCI, PCI capable means when we can do the intervention directly, when we can, reperfusion, when we can perform the reperfusion or revascularization, where we can, get the plaque out and put the stent. Okay, that is called PCI capable hospital. And where there are no cath lab available, where there are no revascularization lab available, we call them non-PCI capable hospitals. So if the patient is directly going to the PCI capable hospital, seen to the cath lab for the primary PCI. Primary PCI means the PCI, first PCI. Okay, primary PCI means the first percutaneous coronary intervention, right? And then directly we should go for device time. Device time means FMC is first monitoring center or first medical contact. Okay, when the patient is coming to the FMC, first medical contact, within the first medical contact, patient should undergo the PCI within 90 minutes. Within 90 minutes, if the hospital is PCI capable hospital. Okay, and it can go up to the delay of 30 plus minutes also, like 120 minutes. Okay, so patient must go under PCI within 120 minutes if the patient is going to the PCI capable hospital. If the patient is not going to PCI capable hospital, then we should always try to reach within time of 120 minutes, like transfer for the primary PCI, and time as soon as possible and less than 120 minutes. Okay, less than 120 minutes we should go for. And if there is no time, if the time is more than 120 minutes, then administer fibrinolytic agents within 30 minutes of arrival. When anticipated, when the time is more than 120 minutes of myocardial infarction or STEMI, then we can give antithrombolytic or fibrinolytic agents, right? And then urgently we should shift the patient for PCI. Okay, and then definitely the complete diagnostic angiogram would be done. And after angiogram, based on the vessels plaqued, based on the vessels involved, based on the size of the clot, based on the length of the clot, and based on the number of clots, we should always go for PCI or CABG or medical therapy. If medical therapy means if there is no clot, if there is no proper clot, or if the major clot is less than 70%, okay, then we should consider the patient for medical therapy. If there are more than 70% blocks, and which are considerably major blocks, like in PCI, and LMCA or LCX or LAD or RCA, these are the vessel names, as I told you that day. Like LMCA is left main coronary artery, or RCA is right coronary artery, or LAD is left ascending descending aorta artery, and then LCX left circumflex. So these are the major arteries. If in these major arteries the plaque is more than 70%, we should definitely go for PCI. Or if there are considering the age, considering the gender, considering the medical history, and considering other factors, lumen size and all, we should decide whether the patient can go for PCI or CABG. Okay, and if there are no blocks or less than 70% blocks, then we can go for the medical therapy as well. Okay, so this is how we consider STEMI patients, because this is the emergency patients always. So that's how we consider, and that's how we decide the patients for treatment or for the PCI, right? Now I'll share the guidelines with you. Yes. So we have even 2020 guidelines, but they have changed drastically. So the changes are kind of tough to understand for newcomers. So let me take, because these are easy to understand guidelines. 2017 are easy to understand guidelines. Okay, so these were developed in 2017 by European Society of Cardiology. Okay, and these were published in 2018. All right, so these are the guidelines for STEMI. Okay, so here you can see there's the table of content, everything. They have given definition of acute coronary myocardial infarction, epidemiology of ST segment, elevation myocardial infarction, initial diagnosis, relief of pain, breathlessness, anxiety. But we'll not discuss these things. We'll discuss the therapeutic things, whatever is required and whatever is very important. Okay, so let me start with the important part. Like if the patient is coming to the hospital and what you have to look into. So here, see, look at this diagram. This is the mode of patient presentation, component of ischemia time and flow chart. Look at this. See, this is very important to understand, guys. This is very important to understand as we are seeing for the first time, and you guys have to understand this. So patient's delay and emergency system delay. Okay, patient's delay, emergency system delay, and the system, the entire hospital system delay. So this is total ischemic time they have given. FMC is first medical contact, emergency system, right? This is EMS, emergency. And then if the patient get called, a patient called the hospital and the ambulance reaches, the emergency system reaches, or in that case, again, if the patient is in the non-PCI center, these are the conditions where patient do not have the PCI center. Okay, where the patient is not having the PCI center available. So in that case, either patient will get the emergency system. Emergency system means the ambulation, or if the patient is not having the ambulation, but he reaches the non-PCI center. Okay, and the patient is diagnosed with STEMI. Patient is diagnosed with STEMI based on the troponin T, based on the raised biomarkers, troponin T or I or CKMB, or based on the ECG. Okay, and then echocardiogram also. So first the patient is diagnosed with an STEMI. Now there are the timelines. If there is less than 120 minutes, then patient can directly go for primary PCI strategy. Okay, patient can go for directly primary PCI, means percutaneous coronary intervention. Patient can directly go to, or the doctor should take the patient directly to the emergency room in the intervention lab, and they should perform the PCI after angiogram. I mean, based on the angiogram, whatever are the results of angiogram, patient should go for PCI. Okay, and reperfusion by wire crossing. Reperfusion means wire crossing, or reperfusion means the reflow of the blood in the plaqued artery. Okay, means they will suck the plaque out of the vessel, out of the artery, and the blood flow will be again there properly. Okay, so that is called reperfusion. Okay, that is called reperfusion or reflow, or revascularization. Vascularization means the proper flow again. Okay, proper flow again once, because they are removing the entire clot and the proper flow is maintained again, and we can put the stent at the place of plaque, because there are the high chances of redevelopment of the plaque at the same site. There are the high chances of reperfusion, because injury is still there. So to avoid that injury and the redevelopment of the plaque, we should keep the stents. Okay, so stents are, as I told you, stents has a big history. It was started with bare metal stents. Bare metal stents means the metal stents. Okay, metal stents were put, but after bare metal stents, they came up with DES. Okay, DES is drug eluting stents. So drug eluting stents are quite technology enabled and quite modern, which is these stents are enabling the drug to what we say secrete at the site of the injury. So these drugs are already there at the surface of the stents. Okay, the drugs are tacrolimus, and there are multiple drugs which can be enabled or which can be coated at the surface of the stent. So these are the slow perfusion drugs, or these are the slow delivery drugs. So these drugs are ongoing for the longer time from the stents, and stabilizing the condition at the site of injury. Okay, these are stabilizing the condition at the site of injury, and they are reducing the chances of redevelopment of the plaque, right? So that is called primary PCI. And nowadays even there are the absorbable stents. Okay, now the latest development is absorbable stents. Absorbable stents are like in the world there are the absorbable stents available from multiple companies nowadays, but there are only abort stents which are FDA approved. Okay, though absorbable stents are from the abort. Okay, so those are like, when we put the stents, these stents will be absorbed by the skin. Okay, absorbed by your circulation, absorbed by the body completely. There'll be no stent at all after some time, after a year or after two, because these stents are made of biodegradable substances. Okay, biodegradable substances or medicines itself. So these stents will be absorbed. So how, see, they have developed, and how the history has involved in this. They have started with the 100% metal stents called bare metal stents, and from bare metal stents to then drug-eluting stents, and from drug-eluting stents to nowadays absorbable stents. Okay, so these absorbable stents are not causing harm, but these are getting absorbed by the body itself. There are pros and cons also. Always there are the pros and cons for everything. So there are side effects also. There are bleeding profiles. There are the redevelopment of the plaque, recurrence of the MI. Multiple things are there. There are the pros and cons with all the types of things, but the development, the science is developing. So there are there are the multiple developments even in the myocardial infarction treatment. Okay, so if the patient is less than 120 minutes, we should directly take the patient to primary PCI. And if the time is more than 120 minutes, then we should go for fibrinolysis strategy. Okay, we should go for fibrinolysis strategy, and then think of later for the reperfusion. Okay, and if the patient is coming to the PCI center, we can directly take the patient to the PCI strategies. We can directly think of the PCI, right? So this is the mode of things. And then see, okay, see, look at this strategy clock. Look at this strategy clock. 0 hours, 0 minutes, 10 minutes, 90 minutes, 2 hours, 24 hours. So how do we decide for the treatment? That is very important. Timings are important. So today we are going to discuss these timings importantly. See, timings are important. Strategy clock. This is called a strategy clock for STEMI patients, right? Suppose the ECG has diagnosed the patient with STEMI. Okay, then if the patient is coming to that hospital in less than 120 minutes, primary PCI is directly going. Okay, if the patient is taking more than 120 minutes, fibrinolytic strategies. Now bolus of fibrinolytic and transfer to the PCI center. If there is 92, there are 60 to 90 minutes. If there is a 60 to 90 minutes time, so what is the condition here? If the patient is getting myocardial infarction, if patient is not supposed to reach the hospital, and if the timeline is more than 120 minutes, so within 60 to 90 minutes, we can start the fibrinolysis strategy and directly take the patient to the PCI center. Okay, and if definitely less than 120 minutes, less than 2 hours, then definitely wire crossing reperfusion. Okay, and then see, now 60 to 90 minutes meet the perfusion criteria. If the patient is meeting the perfusion criteria means PCI, then definitely go for the routine PCI. Otherwise go for the rescue PCI. Rescue PCI means, rescue PCI is called as emergency. Okay, not primary, but that is called as emergency PCI based on the conditions and based on the different techniques. In that case, risk is very, very high. If the patient is not meeting perfusion criteria and time is really more, okay, and fibrinolytic agents were given, then in that case we should go for rescue PCI. Okay, then let me tell you about the important time targets. Okay, here are the important time targets, guys. See, maximum time from first contact to ECG and diagnosis. Within 10 minutes, patient must be diagnosed with or for MI. Okay, within 10 minutes, patient must be diagnosed for MI within 10 minutes of the symptoms. Maximum time from first medical contact to ECG and diagnosis. If the patient is reaching hospital within 10 minutes, patient must be go for the diagnosis. Patient should get the final diagnosis and ECG done. Okay, ECG must be done immediately when the patient is reaching hospital with the chest pain and you're suspecting that patient is having myocardial infarction. Okay, and then maximum expected delay from STEMI diagnosis to primary PCI. To choose primary PCI strategies over fibrinolysis, less than 120 minutes. You should not wait for 2 hours or more than 2 hours to decide what the patient must undergo. whether the PCI or whether the fibrinolysis. Okay, you have to choose and work on and start the therapy within 120 minutes. Okay, look at this: maximum time from STEMI diagnosis to wire crossing in patients presenting at the primary care hospitals. Okay, at the primary care hospitals, if the patient is reaching at the center, okay, if the patient is reaching at the PCI enabled hospital, then there should not be delay more than 60 minutes. Okay, if the patient is reaching to the PCI enabled hospital, patients should not be delayed more than 1 hour. Otherwise, there are the high risks for the mortality. There are the high risk for periprocedural clotting. There are the high risk of periprocedural bleeding and ultimately the death. Okay, ultimately the death, right? And cardiac, cardiac arrest. There are the chances, high chances of cardiac arrest. So, if the patient is reaching PCI enabled hospital, it should not be delayed more than 60 minutes. It should not be delayed more than 60 minutes at all to go for the PCI. Okay, maximum time from STEMI diagnosis to wire crossing in transferred patient, like suppose patient is in the secondary primary care center, not primary PCI center, primary care centers, like suppose patient reaches to the hospital and patient needs transfer to the tertiary care center where the PCI is available, then the timeline is less than 90 minutes. Less than 90 minutes, patients must undergo PCI. Okay, maximum time from STEMI diagnosis to bolus or infusion start of fibrinolysis in patient unable to meet primary PCI targets times. See, first thing, remember this. I'll conclude here for you. If you really think that patient can reach PCI center within 1 hour or maximum 1 to 1.5 hours, then reach the hospital and immediately take the patient to PCI. Okay, immediately take the patient to the PCI lab or to the intervention lab and perform the PCI. Understand? If you think the patient cannot meet the criteria of 2 hours of reaching the hospital, which is PCI enabled, then start the fibrinolysis therapy, infusion of the fibrinolysis therapy within 10 minutes. So here, understand, if you really think the hospital cannot be reached within 2 hours or 90 minutes to 2 hours, then immediately start the fibrinolysis. You should not delay the fibrinolysis also. So time delays from the start of fibrinolysis to evaluation and its efficacy is 60 to 90 minutes. Okay, success or failure you will get in 60 to 90 minutes, and you should not waste the time to reach the hospital in that time. Okay, time delays from start to fibrinolysis to angioplasty, it could be 2 to 24 hours if the fibrinolysis is successful, if the drug is successfully working in the patient, if the patient is survived, then you should reach the hospital and the patient must undergo the angiography and then decided to the angioplasty. It must be within 20 to 24 hours. Okay, you understand? So if you are thinking the first medical contact to ECG diagnosis for the diagnosis should be 10 minutes, should be less than 10 minutes. And if you really think that you can reach the primary hospital, primary PCI enabled hospital, then patient must undergo the PCI within 60 minutes. And if it is a transfer, then 90 to 120 minutes. And if you think the patient cannot reach the PCI enabled hospital, then you should immediately start the fibrinolysis. Okay, and you will get the success or failure within 90 to within 60 to 90 minutes. And if the fibrinolysis is successful, then you can delay the timings of angioplasty up to 2 to 24 hours. Understand here? I hope it is clear. Then see, then the next thing here is dose of antiplatelet and anticoagulate. I'll come to this dose of antiplatelet and anticoagulate later. First, let's understand this dose of fibrinolytic agents. Okay, dose of fibrinolytic agents and antithrombotic co-therapies. Antithrombotic co-therapies with the our antiplatelet therapy. So if we have to start, then the first thing, dose of fibrinolytic therapy is streptokinase. So streptokinase can be given bolus or IV transfusion. IV infusion. Okay, IV infusion, it can be given 1.5 million units over 30 to 60 minutes. IV. Okay, IV infusion. Okay, so 1.5 million units over 30 to 60 minutes. Okay, specific contraindications, if the previously also streptokinase was given, or or any any striplase was given, then we should not give streptokinase. Streptokinase should not be given again to the patient if the patient has already treated with streptokinase. This is the specific contraindication for streptokinase. If you have to select antiplase TPA, which is also known as, so 15 milligram IV bolus, or IV bolus we can give, or 0.75 mg per kg over 30 minutes up to 50 mg, and then 0.5 mg per kg over 60 minutes up to 35 mg additional. Okay, so 85 mg we can give, up to 85 mg we can give within 1 hour. Okay, if it is retiplase, then 10 units plus 10 units, and the gap must be 30 minutes. Okay, then the gap must be 30 minutes. Tenecteplase, if it is tenecteplase, single IV bolus 30 mg, 6000 units if patient is less than 60 kg, and 35 if patient is 60 to 70 kg, if and 40 mg if the patient is 70 to less than 80 kg, 45 mg if the patient is 80 to 90 kg, and 50 mg if the patient is more than 90 kg. It's recommended to reduce a half dose if the patient is more than 75 years of the age. Remember this. So in case of tenecteplase, if the patient is more than 75 years, then the dose will be half, like 15 mg if the patient is less than 60 kg, or 20 mg if the patient is 70 to 80 kg, and 25 mg if the patient is more than 90 kg, but the age is more than 75 years. Okay, and then definitely you must know that the doses of antiplatelet therapies are, there are two types of antiplatelet therapy: aspirin and clopidogrel. And clopidogrel is P2Y12 inhibitors, and along with clopidogrel there are prasugrel, there are these what we say, ticagrelor or canaglor. So aspirin loading dose, as we have discussed that day, is 150 mg to 300 mg orally. Starting dose we can call it, okay, we call it a starting dose or loading dose, and then we can give 75 mg to 250 mg per day. 150 mg usually in India, 75 mg to 150 mg per day we give. Okay, and clopidogrel 300 mg orally we give as a loading dose, and then we can give as a maintenance dose 75 mg per day. Okay, and then doses of anticoagulant, doses of anticoagulants co-therapies. If the patient is less than 75 years of the age, enoxaparin we can give, or UFS we can give, fondaparinux we can give. But remember, these drugs are recommended only if the patient is having the history and patient is meeting the criteria to start anticoagulants. Okay, patient is meeting the criteria. Usually in India we do not give for permanent, or we do not start these therapies. But in case in all the cases in India also, peri-procedural we give UFH or enoxaparin. Okay, or maybe fondaparinux also we give. Why peri-procedural? Because we have to stop the clotting at at the table of angiogram or angioplasty. That's why we give these drugs, GP2B3 inhibitors, or enoxaparin, or unfractionated heparin. Like these drugs are given only peri-procedural. Okay, remember this. For all the patients, if you think these drugs are not given in India, these drugs are given, but only peri-procedural when we take the patient for angiograph, or when we take the patient for angioplasty, which is also known as PCI or PTCA. Then we give these drugs peri-procedural, maybe one dose, one shot, two shot, three shot. Also, based on the duration of the procedure. Sometimes when the procedure is finishing in 15 minutes, angiogram is finishing in 10 to 15 minutes, then we give it. No. Okay, someone is asking, if we are starting fibrolysis agent, it's taking 30 minutes to 60 minutes. See, you are not taking the patients by walking. You will be definitely taking the patient in ambulance, right? You will be definitely shifting the patient in ambulance. So first of all, that And then if you are giving the fibrinolytic agents, means you are very well aware that patient is not reaching to the PCI enabled hospital within 2 hours. Then only you have to start the fibrinolysis. So you are contraindicating your own statement here. As I told multiple times, you must think of the timings. If you think patient cannot get into the PCI enabled hospital, then only within 120 minutes, then only you should start the fibrinolysis. Okay, then only you should start the fibrinolysis, right? And then if you are taking the patients, you are not taking by walk, you are definitely taking in the in the ambulance, right? So these are the things you should always follow. Now let's come to the fibrinolytic therapy. Not this, I think we have missed something. Yeah, so doses of antiplatelet therapies, like if you are giving aspirin, loading dose must be 130 152 to 300 mg loading dose, and then 75 mg per day. Clopidogrel 600 mg loading dose could be 300 to 600 mg. And then you can work on the maintenance dose of 75 mg per day. Prasugrel loading dose could be 60 mg, loading dose could be 60 mg, and then the maintenance dose could be 5 mg per day. Okay, ticagrelor loading dose is 180 mg and maintenance dose is also 180 mg, but twice daily, 90 mg twice daily. Okay, loading dose 2 tablets can be given once, like 180 mg, and followed by the maintenance dose of 90 mg twice daily BID, right? And then if you are giving the anticoagulants, then you should definitely go for abciximab, or if you're going for eftidomide, or if you're going for tirofiban, then the doses are this: bolus of 2.5 mg per kg IV, infusion for 12 hours. In case of eptifibatide, it is double bolus of 180 microgram per kg for given at the 10 minutes interval up to 18 hours. Tirofiban 25 microgram per kg over 3 minutes, followed by a maintenance infusion of 0.15 microgram per kg per minutes up to 18 hours. These are the if you are supposed to given, if the patient is in the need to take the anticoagulants. Okay, and parenteral anticoagulant therapies, unfractionated heparin, you can give 70 to 100 international units per kg, or enoxaparin 0.5 mg per kg IV bolus you can give. Or if you are giving so let it be, I mean, that's okay. So these are the things if you are giving, but peri-procedural, definitely it is definitely needed to take. Okay guys, peri-procedural, it's definitely needing to take. So contraindications for fibrinolytic therapy, very important. Contraindications for fibrinolytic, you should very careful about in case giving the fibrinolytic therapies. So absolute contraindications for fibrinolytic therapy: previous intracranial hemorrhage or stroke of unknown origin at any time. If the patient is having intracranial hemorrhage, previous hemorrhage or previous stroke, you should not give fibrinolytic therapy. Okay, you should not go for fibrinolytic therapy. If the patient is having ischemic stroke in preceding 6 months, in last 6 months, if the patient is having ischemic stroke, hemorrhagic stroke at any time, you should not give. And if the patient had the ischemic stroke within 6 months, we should not give. Central nervous system damage or neoplasms or arteriovenous malformations, not recommended at all. Recent major trauma, surgery, head injury, recently means in the preceding months, we should not recommending the fibrinolytic therapy. Gastrointestinal bleeding within past month, not at all recommended. Known bleeding disorders like menses, excluding menses. Okay, known bleeding disorders excluding menses, like maybe the patient is having nose bleeding or any other kind of bleedings, then you should not give the fibrinolytic therapy. Okay, non-compressible punctures in past 24 hours, like liver biopsy, lumbar punctures, you should not go for the fibrinolytic therapy. So these are the absolute contraindications for if you are thinking of going for fibrinolytic therapy, Altiplase, tenecteplase, or anything. These are the relative contraindications, not absolute, but relative contraindications, like minor. So transient ischemic attack in preceding 6 months. Oral, if the patient is on oral anticoagulant therapies, then you should not go for, you should not go for fibrinolytic therapy. Maybe pregnancy or within 1 week of postpartum, not at all recommended. Refractory hypertension, if the refractory hypertension is there, if the hypertension which is shooting up at this time, not at all recommended. Advanced liver disease, not at all recommended. Infective endocarditis, not at all recommended. Active peptic ulcer disease, we should not give. Or prolonged resuscitation or trauma patients, cardiac arrest patient also, we should not go for, fibrinolytic therapies. So these are the things we should be careful always, guys. Okay, and these are the drugs, and the dose modifications in the chronic kidney problems, like aspirin, no need of dose adjustment even in stage 4 or stage 5, stage 1 to 3, no need of dose adjustment for aspirin, clopidogrel, ticagrelor, or prasugrel. Okay, no need to adjust the dose for stage 4 for CKDs, and ticagrelor and prasugrel are not recommended in stage 5 CKDs. Prasugrel, enoxaparin are not recommended at all in stage 5 CKDs. Okay, right? And ticagrelor also, these are not recommended in case of the patient is in stage 5 CKD. Remember this. Okay, sorry. So we should be careful. I mean, for aspirin and clopidogrel, no dose adjustment recommended in stage 4, stage 5 also, but in stage 5 kidney problems, ticagrelor, prasugrel, and enoxaparin not recommended. Okay, unfractionated heparin, no dose adjustment required in any case. Okay, in any case. Fondaparinux is not recommended in kidney problems, like serious kidney problems, like CKD 4 or 5. Bivalirudin also not recommended. Eptifibatide also not recommended, and tirofiban is also not recommended in those cases, right? So these IV bolus or IV infusion anticoagulants are not recommended in case of CKD 4 or stage 5, right, guys? So that's all for today. I think you must read these things, and these are the maintenance and thrombolytic strategies for ST elevation myocardial infarction. We should always give at least for 6 months. The dual therapies we should give for 6 months, and after 6 months we should decide what we have to give, and at least for 12 months we should give statins and aspirin, and then we should decide. I mean, these are the guidelines says, but usually in India we practice for lifelong. At least at least aspirin or single antiplatelet drug, right? And we should give, along with that, we should give lipid lowering therapies, nitrates if the patient is symptomatic, if the patient is getting any kind of symptoms. So, and patient will be guided for the diets and exercises. So that's all, guys. So any questions now from your side? I'll be taking the questions. If we can't administer fibrinolytics, then what should be considered in case of contraindications? Nothing. We should not consider anything. We can consider anticoagulant if it is possible, like tirofiban, or we can give tirofiban or UFH in case. Otherwise not recommended. Then we should think of the patient to take to the PCI. Otherwise patient can definitely die if you are giving fibrinolytics in case of contraindications. Yes. Anything else, guys? Please ask your question. Suit up. Bleeding, hemorrhage, stroke. There are multiple things where we need this, and then redevelopment of MI. Okay, redevelopment of MI. So we should always be careful and keep the patient in ICU for 24 hours at least to monitor. And within that time, we should think of the options of revascularization. Okay, any other questions, guys? Okay, so from next class, we'll be discussing cardiomyopathies. I mean, there are, I think, 1 or 2 classes. So we'll be discussing cardiomyopathies. Okay, guys. The case. Okay, thank you. And we are releasing, I'm sorry, I was supposed to, release the second series of this, the annual course, second series of the annual course. I was supposed to release on the 29th of September, World Heart Day, but I got COVID, and I could not convey my syllabus to my team, so we could not release it. But before ending this, we will definitely release it, and I invite all of you to register for gastro and hepato course, because that is at least almost free of cost for you. That is 12 weeks course, that is 3 months course, and you will be learning the entire gastroenterology in series 1. So please go and register today if you have not registered for it. There'll be only one class on Sunday afternoon, only one class on Sundays. Okay, so you'll be learning a lot, and that course is affiliated by the university, Gitanjali University. Okay, three-month certificate course. If the patient present with comorbid conditions like depression, diabetes, depression, lifestyle disease, coagulation disorders, then what will be the treatment choice? See, if the patient is coming up with the depression and lifestyle diseases, then definitely we should not look into much modifications of the treatments. But if the patient is coming with the coagulation disorders, then we should be very careful in using fibrinolytic agents. We should not use if the blood lithiasis is there, if the blood related problems are there, if the patient is in a stroke or a patient is on anticoagulants, then we should not start the fibrinolytic agents at all. Okay, and we should also look into if we can use these antiplatelet drugs. Okay, we should look into those. We should analyze the CHAD score. There is MI CHAD score for for the use of antiplatelets and anticoagulations. So we should consider those scores, we should measure those scores, we should calculate those scores, and then we should go for the utilization of these anti thrombolytic agents. In case of DIC, patients would be on thrombolytic therapy. What is DIC? I don't understand. Dr. Venkat. Okay. Coagulopathy. Okay. Coagulopathies. So in case, definitely, if you are asking for the recommendations of antithrombolytic or fibrinolytic agents, we should not at all give. These are not recommended because patient is already on thrombolytic therapies. Okay, I mean, patient is already on patient is having these coagulopathies, or as I told you, blood lithiasis, blood related problems. So we should not we cannot recommend the anticoagulation therapies or thrombolytic or fibrinolytic therapies in that case. Okay, thank you. Okay, so guys, take care, and we'll see you soon with the next class. Okay, take care, guys. Bye, good night.